Good afternoon. This is Dr. John Bennett broadcasting from Miami. Today we have another in the weekly series of Larkin Hospital TV, neurosurgical channel Hangouts, every weekend, Saturday at 2 o'clock. Today we have the pleasure of having Richard Mendel MD, spinal neurosurgeon from Tampa, Florida, who's going to talk about updates on treatments of gliomas. And we have a distinguished group of panelists. We'll start by on the left side. We'll start with Carlos. Introduce yourself, and please, and we'll go from there. Then we'll turn it over to Richard. Hello, Carlos.
Hello, good afternoon with everybody. Thanks for your invitation, John. I am very interesting for today because the theme is a very interesting. It's about management of brain gliomas in a low grade.
Very good, Carlos. And please mute yourself when you're not speaking, okay? Okay, yeah. Eleonora.
Good afternoon, everybody. My name is Eleonora, and I'm a final year medical student. Well, I'm a graduate student from Sapienza University in Rome, Italy.
Very good. Welcome, Eleonora. And Frederick, a late arrival. Hi, Frederick.
Hi, back again from Belgium. Yeah, ready for another amazing hangout.
Great. Well, welcome, Frederick. And Jesse.
Hello, everyone. It's Jesse Contra here in Philadelphia. I'm a graduate student looking forward to another session by Dr. Mendel. Thank you.
Great. Welcome, Jesse. And Ron Wheeler from Sarasota.
How are you? I'm Ron Wheeler. I'm a urologist interested in prostate cancer from Sarasota, Florida.
Welcome, Ron. And we'll be having some hangouts with Ron about HIFU, innovative treatment that is going to be approved September 1st. And Ben, welcome, Ben.
Yeah, thank you for inviting me again. I'm Ben Mulpuri from Michigan. I'm an internal medicine physician. I'm glad to be here as usual. And yep, look forward to.
Well, I tried to get Ben to sing the Star Spangled Banner, but maybe next week.
Yeah, sorry I'm late a little bit.
Okay, welcome, Richard. It's all yours.
Okay, in keeping, with 2 weeks ago we talked about glioblastomas, and it's just as I was starting to prepare that talk, the June 25th New England Journal came out, and it really covered all the advances in diffuse lower grade gliomas, and that's really the area where we need all the help in. And so I thought we would follow the glioblastoma talk up with what's going on now with, quote, the lower grade gliomas. Glioblastoma is a horrible disease that we really have made very little progress in. But where we can make a dent is in identifying what the lower grade gliomas are and how they differentiate themselves, and eventually in 2/3 of people turn into glioblastomas over time. So the big question's always been, how can we quantitatively know that something's really a lower grade glioma, and what's the difference between lower grade gliomas? Because, I look back to an article in 1991, and it was done by Peter Black at the Brigham and Women's. He was the chairman there for a long time. And he described the World Health Organization's classification of gliomas and what we call diffuse lower grade gliomas all the way up to glioblastomas. And as you read the article, it makes sense, but there's nothing quantitative or really that scientific about it. What you see are really just the histologic changes that go into evolving into the glioblastoma. So I think that recently you've heard a lot of academic people criticizing genomics and big data, and they've said that genetics and all the genomic analysis haven't delivered what we had hoped. And when you hear that, you always know that these are old. They're a little bit older. They're not as imaginative as they were, and you need better, better thinking. The genetics and the big data, those are just tools. And so it's funny that you're getting all this flashback about genetics not delivering what it had promised, when it's really just the scientists not being able to, not asking the right questions yet. And so this data came out at a great time because it answers a ton of questions. We've had molecular genetics for years now, but the fruit that it has borne has been delayed because we just didn't have the information yet. But now with all the big data, what you see is that in the genomic analysis, there was analysis done by the University of California at San Francisco combined with the Mayo Clinic, and then they overlaid their data on the UCSF, on the UCSF data and on the Cancer Genome Atlas, and out of those two studies, we got a lot of information. So here's the first article is the Cancer Genome Atlas Research Group, and their article is right here.
Excuse me, Richard. Richard,
yeah.
Carlos, could you please mute yourself because we're getting a lot of background noise, please? Carlos?
That's all.
Carlos, please mute yourself. We're getting a lot of background noise.
I will do.
You know how to mute yourself? Carlos? Can you hear me, Carlos? Yeah, we're getting a lot of, you need to mute yourself because we're getting a lot of background noise from your screen. You know how to do that, Carlos?
Yeah, I will be trying.
No, just mute. At the top of the screen, there's a microphone. Click on the mute. There you go. Okay, that's better. Okay, I'm sorry, Richard. Go ahead.
Hey,
okay.
Richard, can I ask a question first?
Sure.
Yeah.
Can you tell me the incidence of gliomas? What's the prevalence?
Well, unfortunately, glioblastoma is the most common primary cancer, brain cancer, in the world. Now, the thing is that we never did have a good grip on the lower grade gliomas, but the gliomas really range from grade 1 to grade 4. The most common tumors you see operated on are METs, because METs far outnumber anything. But the primary brain tumors, glioblastoma is number 1. And it's much rarer in children, and children tend to get what are called primitive neuroectodermal tumors, and those are really usually more in the brainstem and posterior fossa, whereas glioblastomas are almost always in the frontal, the frontal, temporal, occipital, and parietal areas in that order. But GBMs are the number 1 primary tumor, but the problem is that once you have a GBM, your lifespan is really limited. You know, you're looking at 6 months to a year, sometimes as long as 15 or 18 months. But when you have a lower grade glioma, and this will be borne out, and it has molecular markers that place it in a grade 2 or grade 3 grouping, you can live from 8 or 9 years, whereas the more aggressive ones, you may only have 5 years, and then there are those that convert slowly over time into GBMs. But now from these studies that I'm going to show you, we're really able to stratify these tremendously better. That's the importance of these articles.
Okay.
Is that we really have an idea now that is both not just, it's a bit more quantitative than we ever had before. And this is just due to tremendous numbers of people being enrolled in these studies and the discipline that UCSF and Mayo exercise and the Cancer Genome exercise. They had thousands of glioma patients, and they had, I believe it was 11,000 controls. So here's the first article, and that's page 241, 249. And then I'll show you the second article. But here's the problem with grade 2 to grade 4. It's kind of an amorphous spectrum, right? Grade 2 are what we call diffusely infiltrating. And those are, pathologically, we describe these things as having oligodendroglioma type pathology or histology, and we tend to associate an astrocytic quality, which is more aggressive in a histologic term, to grade 3 tumors. And a lot of the problems that we've run into is that the World Health Organization's classification system has really been histologically based. And now I think for the first time I know of, at least in terms of neurology, neurosurgery, this is the first time I know of that the World Health Organization classification is going to be rewritten to include tumor markers and genomic markers for the first time, because they produce a lot more evidence than the histology alone. And also with the tumors, you have to remember that there's a sampling error in these patients as well. So you're always concerned with lower grade gliomas that there's a sampling error, you don't have good markers to follow. Now you have the markers to follow, and you can make recommendations about treatment modalities and have a much better idea of a patient's lifespan and the tumor behavior. So here's the WHO classification, and this is all outlined by Dr. Black in the 91 article I mentioned to you. They're histologically based. Okay, they're histologically based because we didn't have the molecular cell biology and the genetic information that we have now. Now they're going to be molecularly and marker based. There's poor correlation with tumor behavior for the same reason, and probably the worst point is that there was a high intra-observer variability in the gradation of these tumors. So who asked before? Was it Rob? Here is the prevalence. 2/3 of principal grade 2 gliomas, 2/3 of them, and those are astrocytomas or oligodendrogliomas or whatever they're classified, progress to grade 3 or grade 4 tumors. Once you're a grade 3, once you're a grade 4, your lifespan is going to be limited. And the problem with grade 3 is it's very likely to transition as well into grade 4. So this is the contributions of the Cancer Genome Atlas, okay? They looked at only grade 2 and 3 gliomas, so that they're not including GBMs in here. And what they found was that there's this 1p to 19q co-deletion. Now, finding that was important. So that got laid on top of clusters of other deletions that happened. And so now they're calling their analysis a cluster of clusters, where they're laying on top a lot of information about subgroups and then following the subgroups out like you would in a Kaplan-Meier graph to figure out which ones are important. So what they decided was that the big difference was between this IDH and IDH1 and IDH2 variants. Those are two subgroups. And then these two differentiated each other by the presence of whether they had this co-deletion or not. Now, I know when I'm explaining this, it's too wordy, but the slides in these in the New England Journal were very good. They were like Venn diagrams, and I think and multicolored too. I think you'll get a better sense of the significance if you look at those articles. And I looked at them on the nemj.org online. They're really great slides. But anyway, now what happened was the people at Mayo Clinic / UCSF, that team, they looked at groups, and these were based on that 1p19q, IDH, and TERT promoter mutations. Now, I know this, is wordy, but I think the diagrams bear it out better. Now, if you look on pages 2499 through 2508 online, the diagrams are really very good. And what they found was this, that if you were triple positive, meaning you had all three markers positive, then there was a big correlation with a histology that might be considered oligodendroglioma-like, which is lower grade, and that grade 2 tumors were much more common than grade 3, and no glioblastomas evolved out of this group at all. Okay? So that's great. Now we know that a triple positive tumor for these markers rarely ever, never evolved to a GBM. So, that's somebody you want to pay attention to, and you probably don't have to consider you don't have to consider going to big, your stronger agents and most stringent therapy right away. However, when you had the IDH mutation, but you didn't have the co-deletion, okay, so just not having that one co-deletion, that made them correlate much more with an astrocytic histology, and they were much more common than the grade 2s were much more common than grade 3 or grade 4. So triple positive is very good, but the IDH with no co-deletion at all was beneficial as well. Then when you look at in grade 4, the tumors are much more common. The really malignant tumors, grade 4, were much more common when there was the TERT mutation only, or when there was triple negative status. Triple negative status was, highly correlated with GBMs. However, the TERT mutation alone was what seemed to be the worst prognosis, and most correlated with GBM. So that's really very significant, because here now you're talking about the most common tumors being a glioblastoma multiforme, and the treatment is really going to come down to whether it was a TERT mutation only or whether there's a triple negative status, and maybe there's more room for palliation or some type of improvement there. But what this lets you know is, based on the Cancer Genome Atlas study, is that when you're seeing this IDH1 and 2, there may be other pathways that we're going to be able to develop in the near future to direct treatments towards. It's not going to be as terrible diagnosis as a anaplastic astrocytoma, which is grade 3, or glioblastoma. We may be able to extend the comfort level and lifespans of some of these people somewhat, and maybe not put them all through, really highly toxic treatment plan. I really would encourage you, though, to look at the slides. I was trying to reproduce them a little bit, but
well, Richard, I'll look for them on the New England Journal website.
Yeah, they're all there.
Okay, okay. You continue, and I'll look for them.
Well, really, that's really about it. But this is a tremendous study. It's a big advancement because we never knew anything except the histology, and now that we know what markers we're looking at, this is really a landmark article. I mean, this is the first. I mean, when you compare the 1991 article to now, it's just tremendous how much more information we have now. Because there's a lot of arguments, like I said earlier, that with academics that genomics and genetic information is not providing the data. It's just a tool. I mean, once we got the science and collected the data, it really stratified. It really stratifies very well, and it's going to be a big deal. So that combined with the glioblastoma talk 2 weeks ago, I think you're pretty caught up on what's going on now. And the answer is with glioblastomas, there are many different tumor, there are many different markers, but we didn't know which ones yielded the bad prognosis. Now we know what is more consistent with oligodendroglioma types like grade 2, and what's more consistent with the worsening astrocytic components, which is 3 and 4. I know it sounds ridiculous, but we didn't really have insights into that until now.
Very good, Richard.
And that's it.
Very good, Richard. Another excellent presentation, very clear. And one comment I'd like to make, I think in all areas of medicine with genomics and big data, we'll get better and better identifying cancers and more importantly, biomarkers so that we can try to get cancers as quick as possible. So I'll open it up to the floor for questions from Richard. Don't forget to unmute when you ask a question.
Richard,
Yeah.
My question really is associated with the incidence of this disease. So can you tell me, is it 1 in 1,000 that get this disease, or 1 in 5,000?
Oh, I can look up the prevalence for you, but I mean, with metastases, that's the most common. With GBM, I really don't look. Hey, Ben, can you just Google the prevalence? I mean, GBMs.
Yeah, I'll do it. I'll do it.
The prevalence of GBMs is, the most common primary, but it's not, it's not like it's nowhere near as common as prostate or breast CA, but it's bad.
Gliomas or glioblastoma?
Glioblastoma is 4, yeah.
Okay. Any more questions, please?
The question that I would have, Richard, as well is, can you tell me if any of the Duke research, as they look at cancers like brain cancers using the herpes virus, do you have any knowledge of that? Or
yeah, that's gone back a long way. It's not really, the vectors. They were using a herpes virus vector, but right. As far as the GBM research has gone, it really hasn't yielded very much, and the mortality rate hasn't changed since the 1960s, really. But we do know a lot more than we did in terms of these tumors. The grade 2 tumors tend to strike young people, 30s, 40s, younger people, and they can have a somewhat more indolent course. But the higher grades that appear at older age, those are the TERT promoter ones. Those seem to proceed to a rapid death by evolution into a glioblastoma much faster than the IDH ones do, especially ones that lack the 19p and 1q co-deletion. So, we're getting these people stratified into, the younger groups versus the older, more geriatric groups that have a tumor that's really biologically somewhat different than the ones that bother the younger patients. But you know, it's the first really solid biomarker that's replaced histology in neurosurgery or neurology. So it's pretty interesting.
Just a quick note on the incidence. 1 in 165 men and women will be diagnosed with cancer of the brain. Incident rates for malignant adult brain tumors varies from the state, 5.4% in Hawaii and 13% in Wisconsin. I don't know if that helps at all.
Well, you know, I think that it's important to know how, you know, that these are so common, but the problem is you don't know what brings them to attention, and a lot of people may have a tumor that just don't, you know, that goes on indolent for years, then it gets discovered later, you know, later when it changes its biology. And, you know, children have a lot of lower grade things that can evolve over a great period of time. But, you know, I think it's a still a big advancement. Yeah.
Okay, Richard, just click on your screen share to get off it because you're still on it.
Okay.
Actually, you're showing Ron's wonderful face.
How's that?
Dr. Bennett, did you see I put some incidence and prevalence and?
Oh, okay. Let me talk about that. You want to go ahead and read it, Ben, if you like.
It's about the glioblastomas.
Yes.
The incidence is 1 in. I mean, this is about adults. In adult population, it is 1 in 33,330, and prevalence is 1 in 100,000. And the most common age group is between 45 to 70. The 70%, you know, it happens between 45.
Very rare.
Yeah.
Well, you know, that's the point, is that that's what we thought, but we're going to find out that the TERT mutation only people are actually the ones that get diagnosed quite a bit later, and the ones that are maybe 35 or 40 are not really the TERT promoter ones, but the IDH pathway marker instead. So it does give you some ability to differentiate things.
Okay.
I just think you know, it's really the first really big data study that is rewriting the World Health Organization guidelines, and they are being rewritten now.
It probably get better, correct?
Oh yeah, it always gets better. Well,
Yeah.
what doesn't get better is how dumb we are. We always say, oh well, this technology didn't deliver anything. Well, the technology's new. We have like 100,000-year-old brain, and just takes newer blood to think up the better questions and collect the data, and then it delivers. You know, it just doesn't deliver instantly just because you found you found big genomics. You just have to go through all the data, and the computing power is what delivers it.
Okay.
So,
Which was not available 20 years ago. None of this study obviously couldn't have been.
well, I guess it started to be available by the late 90s, but you know, it took a long time to assemble this data, and these are great studies where they're following people out 8, 10, 12 years. So, you know, we saw the biology of the tumors. So they're going to get a more specific treatment, a more tailored treatment, which are, you know,
Yeah, big
is always good.
big step was when they cracked the gene code. Was I think back in 2002 or 2003.
Vettner and Collins, yeah, yeah.
Carlos, can you hear okay? I think Carlos wanted to ask a question. Okay, Carlos, welcome back.
Yeah. Well, I think that I'm not the expert. I'm just reading the data, and it looks like to me you still want to have tissue biopsy. You want to have tissue, but you're not going to be as concerned about the histology as you are about the tumor markers. And if you have a biopsy, you have the tumor markers, I wouldn't do anything too aggressive if it was one of these TERT mutations, because that ends in glioblastoma rapidly. And that's usually in much older people. But in younger people, if they have an IDH mutation and the co-deletion, those are people that can respond to some radiation. The chemotherapy, I think, is going to get better. I think everyone was pretty disappointed with the gliadil wafers. I think that was carbamustine implanted on a chip and put in the cavity of the tumors. That I don't think that's borne a lot of good results. But I think that as you can get the tumor markers, you need to follow those pathways, and I think that the upcoming articles are going to be their treatment stratification, what they recommend. Still, these tumors are diffuse, and even if you call them contained or encapsulated, they're really not. They're diffuse, and there are fingers of the tumor spreading everywhere. So, great, I told you about a friend who had his glioblastoma resected by a great surgeon, and even though he had a great surgeon, that he didn't get the whole tumor, because that tumor is an invasive infiltrative tumor that replaces normal neural structures. So I don't know what the treatment regimens are now, but at least you know that you can differentiate what are really the better what are the worst actors and what aren't. And I'm waiting to hear what the treatment recommendations are. I'm going to be as anxious as you are to find that out. We're getting a lot of models now from some models of who will and won't respond to some drugs. Like there's a model for the cytochrome P450 system, but I don't know of any trial right now that's been published about optimal treatment for the different types of markers that we've talked about today.
Richard, I was surprised when you said you're very dependent on the tumor markers more than histology. That is kind of, is that because of today is getting more accurate, the tumor markers?
Oh, yeah. I think this is that's nothing. That's not old. That's brand new. I've never heard of that before.
Yeah,
I've never heard of the tumor markers actually replacing the histology to a degree, and that is what's happening.
Yeah, I thought the diagnosis of cancer, the gold standard was get the cell, get the histology, and look at it.
Yeah, but you have to remember, like we rename and recategorize all the same data over and over again. We have biology, then we learn more about cells. Everybody gets impressed with cells, so we call it cellular biology. Then we get interested in microbiology and rename everything microbiology. Then we get interested in molecular biology, rename everything in molecular biology.
Yeah.
And now we're in genetic biology. And when people weren't getting the results they wanted, they said, oh, well, genetics really didn't deliver. So now we're going to start focusing on epigenetics. And epigenetics is just that field of genetics, from genetics down into a smaller scale, where we just didn't have the right questions yet. Now we're starting to get some of the answers. I think it's really very exciting, kind of.
Yeah. Richard, go ahead, Ron.
Richard, I have a question for you. Have we settled the issue regarding the effect of oxygen exposure to brain cancers and the a belief that when oxygen hits these cancers, it enhances growth?
Well,
What do we know?
when you talk about brain cancers as a whole, I mean, it's a lot of different entities, and the most frequent one, as you know, is metastases. But, a lot of that is dependent on what the tumor does to the blood-brain barrier, how badly disrupted the blood-brain barrier is. I'm not really qualified to make a blanket statement about that, but I don't think there's been I think the kind of more cellular physiology that you're talking about, the oxygen response by a carcinogenic tumor, I'm not sure. I mean, I think we still know that what limits tumor growth is, Gompersian growth, and if a tumor outstrips its blood supply, that's when it decays, and that's the amount of information we had to make the diagnosis of a glioblastoma, because a glioblastoma was a grade 2 or grade 3 type of tumor with patches of necrosis in it. Once you saw the necrosis, you knew it was a highly malignant tumor, that it was outstripping some of its blood supply. It was growing so quickly. So, I guess that's a roundabout answer, but I just don't know.
I asked the question primarily because the issues with prostate is such that we can do an MP multiparametric MRI scan and evaluate that patient without a piece of tissue and do the correlates with tissue. So ultimately, I think the game with brain cancers will also be imaging and being able to correlate those images to pathology, such that if we find out that opening the cranium as an example and exposing that cancer to oxygen changes the behavior of the disease, then maybe what we want to do is consider looking at the phenotype, if you will, looking at imaging, and then treating accordingly.
Well, that may be. Right now, there's no reason to think that opening the dura, exposing the brain to air is detrimental. But when I'm talking about biopsies now, I'm not talking about big open craniotomies. I'm talking about stereotactic needle biopsies. So, we're talking about a very small piece of tissue. So, could it possibly get to no tissue at all? I imagine it. I imagine it will someday. I imagine it will, and that'll be based on biology and PET, and we'll see. But my guess is as good as yours. That's all.
That's going to be an interesting field. Go ahead.
Well,
Sorry, folks, about the audio.
I think that you know, I did hear a lot of what you said, and
Okay.
you know, I still think you have to remember that. I mean, nobody's a bigger proponent for stereotactic biopsy than I am. I think it's great, and I think that one day we may not need it. But you have to remember that there's always a sampling error. You know, when you biopsy a tumor, and especially if it's lower grade, and you're really depending that you got the right area. And I think things are going to become much more quantitative than they've ever been in the past, and I think that's a good thing.
Well,
you know, because I mean, when you look, I think, Ron, I think that, you know, the prevalence of like breast cancer and prostate cancer, the graphs look pretty similar, but it's the, you know, the survival and the mortality from breast is so much worse. And, you know, we've done a lot better, I think, with prostate CA, and I don't know. I think we're going to figure out a lot of these pathways in the future, but, you know, it varies on tissue type, it varies on biopsy, and where you're not using biopsy, I'm hoping that you have the mathematical data to show that you're within a high confidence interval, that you're not getting sampling errors. Ultimately, yeah.
Yeah, Richard, you're singing Ron's song because that is his thing, that you can accurately diagnose prostate cancer more by imaging than biopsy. Is that correct, Ron?
That is absolutely correct. Biopsies are actually a very poor tool as a diagnostic modality. Imaging is
for prostate, right?
Yeah. Imaging is the #1 modality for diagnosis of any disease of the body, any cancer, as an example. Beyond that, the question is, what do we do next? But when you compare to in prostate, you compare biopsy, which has a 20 to 40% incidence per biopsy performed, compared to taking an MRI, MP-MRI, multiparametric MRI, and evaluating it, and then having a PIRADS score put against that biopsy. We know predictably what that Gleason score is going to be.
Yeah, but remember, who was the fellow that developed the prostate-specific antigen test?
Okay, Ron knows that.
Yeah, I should know.
Remember, there was an apology that he wrote in the Wall Street Journal, and, you know, millions upon millions of patients have suffered in terms of biopsies that were completely unnecessary for years on end. So prostate, I'm sure, Ronald, you're right, but prostate's kind of an extreme example because it was way, you know, we've way over utilized, and from, you know, maybe because of all that experience with prostate, we have much better ideas about the clinical outcomes now, and you can say what you're saying now because we've followed prostate exorbitantly due to the prostate specific antigen understandings, which were poor. I mean, we had the fellow that designed it never intended it to be used the way it's used, and it just necessitated serial biopsies at 3, 6, 12 months for a long time, and lots of people that never needed it. So, you know, maybe we benefited from that by knowing the biology of prostate better, but we really don't know the biology of brain as much as we'd like to yet. It's going to be a while till we until we have control over it.
Let me just address, if I can, let me just address what you said. I believe the fellow's name is Ablin, who developed the PSA, and I'm not supporting biopsies at all. That's my whole point.
I know that.
What I'm trying to say is that we want to use imaging more, and if we need to have a piece of tissue because of a lack of confidence in the reader of those images, then in fact we can at least target a specific area. We've reached the point in Sarasota where if I identify a cancer on an MP-MRI scan, I can tell you that I know whether that's a bad cancer or not.
Yeah, but the luxury you have of knowing that that's a bad cancer or not is probably an outgrowth of how much information there's been garnered about prostates and the myriad biopsies that were unnecessary for the last 2 or 3 decades. Now, as you know, you don't, like you say, you don't need the biopsy, but brain is that situation now. Brain is nothing like prostate at this time.
Okay.
There's never been the type of like wholesale biopsying because of things like a prostate-specific antigen test, which is really used incorrectly forever.
Excuse me.
Yeah, I think Ron will agree with that. The PSA, too much dependence on it.
Yeah, it's ridiculous. So,
Carlos, any questions? Any more questions, Carlos? Who's the most important guy in the panel?
I think it's been muted.
Oh, well, I guess he's speaking. Ben, do you have any questions?
Yeah. No, not really.
Okay. Any of the students? Hello, students. You're quiet today. That's okay. If you don't have questions, that's fine. No questions?
For the students, just never listen to experts. When people tell you genetics is delivering nothing, that's just because they're old and they don't have a creative head anymore. And that's when you have to start thinking of stuff to do. Genetics is just another tool, and it'll get smaller. By the time you're like old, you'll be studying nanobiology and people will be talking about psychobiology. Yeah, it's ridiculous.
Well, that's one thing the students can bring to the table, Richard, because I know when I was in med school, I didn't study any genomics at all. And Ben, I think you could say the same.
It was biochemistry. Yeah, kind of. We talked about biochemistry a little bit, and it's just we're learning more with better tools, and then we're having people that aren't making the advances because they're not as creative as they were when they were younger, and now it falls to better researchers and younger people to make the advances. This was a big advance, really, it was.
Well, we can ask the students that question. How much genomics do you guys take now in medical school? Eleonora, did you take any genomics courses in medical school?
Yes, we do, but just theoretical ones, so we didn't practice really much. So.
Oh, okay, but like theoretically, like a couple of lectures or a month, or what kind of?
Yeah. A year.
Oh, a whole year.
First year.
Yeah. We in my medical school we had a couple of lectures. That was about it.
Oh no. 2 semesters here.
Yeah, things have changed. How about you, Richard, when you went to school?
No, I mean we had biochemistry and we had some genetics, but things. These things don't come to fruition instantly. That's just how it is. Basic researchers invent the tools, then we collect enough data, and then you get a clinician, and they collect the data over years, and the good data takes a long time to ferret out. It's coming out now. So you're going to hear a lot of people still blabbering about genetics didn't deliver what it was supposed to, and that's nonsense. It is delivering. It just takes time to get good information.
It'll get better. And before we close, any questions, Carlos, or comments from the neurosurgeon on the panel?
I think that at this time, it's important for all people who are doing medicine to study and know very well the biochemistry, to study the genetic compartment, and after that is to correlate with all kinds of brain tumors.
Yeah,
So,
you just yeah.
At this time, for example, I think some years ago, I do one study with recollected data with people with mirror spectroscopy and correlate with the results of the biopsy, and the correlation was less than 50%. I think at this moment we don't have any kind of imaging techniques that will help to us determine on the make a decision what kind of tumor is right in front of us in a tumor. For this time, I think the gold standard is to take a biopsy. Maybe in several years after we'll be have a good imaging techniques that will be supplied the biopsy.
I think Carlos is exactly right. I mean, we still don't know what we don't know, and you don't want to always say, oh, we'll just trust imaging, because there are many countries in the world where you're not getting that imaging. So you have to have an idea of what the spectrums are and where you are and how you can best treat somebody. And it's not, you're not always going to be able to depend on imaging. Here, I'm in Florida, I'm not far from Sarasota. I mean, here there's imaging centers every 2 blocks. It's a wealthy population. But, you know, if we were, I'm sure if we were in the Dominican Republic, there's not as many MRI centers or imaging centers. It still has to come down to the exam and thinking about, you know, the patient. You know, not the patient's molecules, but the patient. So there's going to be lots of times when you're just not going to have the option to image.
Very good. Any more questions, anybody? Comments? Okay, Richard, we'll wrap it up. Thank you very much for taking the time.
Yeah, sure.
And
sure.
We'll see you next week and figure out the topic before then. And thanks to all the panelists for muting and being part of this discussion. So
muting.
Thank you. Okay. Thank you very much. You can hold on. I'm just going to stop the broadcast. Okay. Goodbye.